Hi, I'm Sushant and welcome to this online tutorial by Quest. One of the commonest presentations to us in our OPD or emergency departments are patients presenting with fever. Such acute febrile illnesses would have seasonal peaks around the months of monsoons. In this tutorial, let's study an approach to these patients with acute febrile illness. And our focus would be on 4 important diseases that are found across India, namely malaria, dengue, chikungunya and leptospirosis. What is common to all of them is of course fever. Very often this is going to be high-grade fever lasting for days to weeks. Patients can have associated chills and can have associated complications like rashes, bleeding disorders or systemic involvement in form of renal, liver or CNS involvement. Let's first understand malaria because that's a big problem in India. Patients who have malaria before they have fever would start mounting chills. These chills would last for around a period of 20 to 60 minutes and following that the temperature would start rising. The fever is very often going to be high grade fever lasting for hours, and following fever patients would have episodes of sweating or diaphoresis which would last for around half an hour. Now the fever that occurs in malaria is associated with the rupture of erythrocytic sezones which occurs every 3rd to 4th day. So patients would have fever which would typically, if left untreated, repeat every 3rd to 4th day. Along with fever, malaria can get complicated and have involvement of other organs. Classically, patients can have neurologic involvement and that is known as cerebral malaria. Here, patients can present with altered sensorium and sometimes can present with seizures. Acute kidney injury is a very dreaded complication of malaria. Patients can have renal injury because of dehydration, because of associated shock, and there can also be sequestration of the parasite within the renal tissue which contributes to the renal injury. One parallel thing that these patients are having is they can have severe hemolysis. Remember, these RBCs are bursting open because of the parasite. And such hemolysis can lead to dark colored urine, giving malaria its name, black water fever. Another dreaded complication which we see very commonly in our urban scenarios is patients coming with acute respiratory distress syndrome. This is commoner with vivax malaria than with falciparum malaria. Jaundice can be another important complication, and this could be because of either direct liver injury or because of the hemolysis that we have mentioned. Apart from these major complications, patients can also present with hypoglycemia very commonly in malaria. Patients can have hemolytic anemias which could be very severe, and patients can present with metabolic acidosis. If we compare malaria with dengue again comes with high grade fever. But patients of dengue can have a triphasic course. To begin with, patients would have fever, and this fever would be associated with severe headache, myalgias, arthralgias, and a typical rash. Patients would also complain during this time of fever of retroorbital pain. This stage of fever would typically last for 3 days or sometimes up to a week. And characteristically, during this period, patients would present to us with a low WBC count, might have a slightly normal to low normal platelet count, and very often would have elevated liver enzymes. As this phase passes off, as the fever settles down, patients would enter into the second phase, which is a more critical phase. This is the time when vascular leak phenomena starts, and as the vascular leakage starts, patients start manifesting hemoconcentration. In the lab parameters, this is reflected by an increase in hematocrit. Remember, when I'm seeing a patient of dengue, one of the very important tests for me, more important than platelets, is the hematocrit value. Also, due to vascular leak, patients are also coming with hypoproteinemia. Together, this vascular leak would lead to pleural effusions, ascites. Patients would also complain of abdominal pain, and this is also the time when the platelet count is drastically dropping down. This is going to be manifested with bleeding in form of mucosal bleeding, petechial rashes, and sometimes GI bleeding. This critical phase is also marked by the onset of ARDS. We need to watch out for these patients along with pleural effusion whether there are pulmonary infiltrates. This is also the time when patients of dengue are predisposed to myocarditis. Now in some cases, the vascular leak could be so severe that patients rapidly deteriorate into a hypovolemic shock. This is marked by onset of tachycardia, a weak pulse, and of course a low blood pressure. A very poor sign at this moment could be a poor mental status. Multi-organ dysfunction can set in, and these patients can rapidly deteriorate and suffer cardiac arrest. Mortality is highest during this phase of dengue. Of course, there are patients who recover out of this phase of shock, these are patients where the vascular leak has stopped, and as the result of this, patients are out of the danger phase. So if we look at the complications of dengue, the neurologic complications, the renal complication, ARDS and hepatitis, all of this look very similar to what malaria patients could present with. There are some typical complications which are more likely in dengue. These could be patients can have GBS. Now this is rare, but it is associated with dengue more than malaria. Similarly, a common finding which might not be symptomatic is patients can have acalculous cholecystitis. This could be a finding to watch out for on a sonography if done. Patients, as I have already said, can have myocarditis but can also have myositis, which can lead to myalgias and sometimes elevated muscle enzymes. And of course, the bleeding disorder is much likely in dengue than in malaria. Now a disease very similar to dengue in presentation is chikungunya. The febrile stage is in fact very similar to dengue. The patient would have fever, would have rash, which can be difficult to differentiate from dengue, would have headache, backache, retroorbital pain as well as abdominal pain. But what really marks chikungunya separate from dengue is that these patients have arthritis. This arthritis is very often in the small joints of the hands but can involve multiple large joints as well. And not only is this arthritis in the acute stage of fever, it can last later on chronically for months or sometimes for years together. Now the good news with chikungunya is that systemic involvement and complications are much less likely than with dengue or with malaria. Now apart from these vector-borne diseases of malaria, dengue and chikungunya, there is one more disease that comes very often with monsoons, especially in the urban slums and in those areas which have suffered from floods and have low hygiene. This is leptospirosis. Leptospirosis again comes with fever with chills. Patients can have headaches, very often have myalgias. They can also have renal involvement and liver involvement, which is in fact classical presentation of leptospirosis. But a thing which can differentiate them early on is the conjunctival involvement. They very often have conjunctival suffusion or swelling and can present with conjunctival hemorrhages. Remember, this does not separate them completely from malaria or dengue. Even those patients can have hemorrhages, but the conjunctival swelling is more common in patients of leptospirosis. Patients can also present with meningitis-like picture. This is aseptic meningitis. That means if I do a lumbar puncture, I wouldn't find any bacteria, but patient still has features, clinical features of meningitis. But the classical presentation is a patient of fever presenting with jaundice and worsening renal outcomes. Such a presentation of fever, jaundice and renal involvement gives together the triad of what is known as Weil's disease. Weil's disease is the most severe form of leptospirosis. Remember, not everybody needs to develop Weil's disease. Patients might have fever without Weil's disease, but the classical triad is of fever, jaundice and acute kidney injury. Just like other conditions that we have seen, leptospirosis also puts the patient at risk of ARDS. Patients can have alveolar hemorrhages and that really increases the risk of mortality, and clinically it might look very similar to ARDS except that the patient has severe hemoptysis, and similarly patients can have GI bleeding. Now we have seen the clinical profile of malaria, dengue, chikungunya and leptospirosis. Now let's go to the source. Where are these diseases emerging from? Well, the easiest to understand is leptospirosis. That's a zoonotic disease. It's a spirochete known as Leptospira interrogans, and it is the rat urine which is the most common source for us in humans. This rat urine would contaminate the flood waters, and from flood waters it would enter into the human skin. But the other three are vector-borne diseases. Malaria, for instance, is a protozoan parasite known as Plasmodia. Plasmodium falciparum and vivax are the most common in India. Around 6% of total global burden of malaria is found in India, and of these, 2/3 are falciparum and 1/3 is vivax. We all know that it is the infected female Anopheles mosquito which inoculates sporozoites within the human beings. The parasite then travels to the liver, from the liver towards the RBCs, and it matures within the RBCs. After maturation in the RBC, it causes rupture of RBCs, and at this stage patients have coinciding fever. From the RBC, it further goes on to become the gametocyte, and from here the mosquito will take it back again. The sexual phase of the parasite happens within the mosquito, while the asexual phase happens within human beings. But as it infects the RBCs tend to adhere to each other and cause blockages of the microvascular system, leading to microvascular hypoxia and most of the clinical features of malaria. The parasite also activates cytokines, leading to a pro-inflammatory state and a sepsis-like phenomena. Now, one good part about this is since it requires the RBCs to survive, Variants of hemoglobin like sickle cell or HbC or HbE tend to have a protective effect against malaria. The remaining two, dengue and chikungunya, these are viruses. Both of them have similarity in that both of them are RNA viruses and both of them require the same kind of mosquito. Dengue is a flavivirus and it has 4 serotypes, namely 1 to 4. And the mosquito that is required for its transmission is the Aedes aegypti mosquito. Typically, this is a mosquito found in the urban scenario and it's a mosquito that bites during the daytime. Now, if a patient has an infection with any one given serotype of dengue, that leads only to the features of fever. And very often that is a self-resolving fever. The good part is if I get infected with any one serotype of dengue, I would have a lifelong immunity against it. But unfortunately, if I get the second infection with dengue with some other serotype, now my immune response is going to be associated with vascular leakage. The non-structural 1 or NS1 antigen of this virus is especially responsible for activation of the immune system and associated endothelial damage and vascular leakage. So patients who have the second infection are the ones who enter into the shock syndrome that we saw or enter into the bleeding manifestations of dengue. Chikungunya, on the other hand, is an arbovirus. It also spreads through the Aedes aegypti mosquito as well as the Aedes albopictus. Chikungunya causes endothelial cell damage, it survives in the macrophages, and more importantly, it causes damage to the synovial cells, and that is how it contributes to the features of arthritis. Now let's focus on how do you evaluate these patients and how do you manage them. When we are examining these patients, we are of course looking out for signs of fever, looking out for shock, any bleeding manifestations. We are looking for hepatosplenomegaly, we are looking for any lymphadenopathy. We are examining the chest for any crepitations or crackles to look for features of ARDS. We are of course looking for any finding of fluid overload in form of pleural effusions or HJVP. Investigation wise, we very often need to hurry up, especially if the patient has been hospitalized. So there are going to be some general investigations I'll need, like complete blood count. Here I am looking for presence of anemia. I am looking for the WBC count, which is very often going to be normal except in dengue where it is going to be leukopenia. And of course I am looking at the platelet count. Platelet count, remember, can be low in all of them from dengue, malaria, leptospirosis as well as chikungunya. But dengue and malaria of course are the ones which will have the worst hit of platelet count. I am also looking at hematocrit, especially because hemoconcentration is a feature of dengue. I am looking for the renal functions, that is serum creatinine, and the liver functions, that is bilirubin and the SGOT, SGPT levels, because malaria, dengue and leptospirosis very commonly can have renal as well as hepatic complications. I am going to monitor the patient's urine output and I am looking for any signs of hematuria for patients of malaria as well as dengue. It's a good idea to have the coagulation profile done, especially when I am looking for evidence of bleeding. I would do an ECG to look for myocarditis, and I'll do a chest x-ray to look for associated pleural effusions or ARDS. Of course, I would do an x-ray to rule out pneumonia as well. An important test for these patients is going to be imaging of the abdomen using an ultrasound. This will not only show me hepatosplenomegaly, but in cases of dengue, it might show me acalculous cholecystitis, and it might also sometimes show me features of pancreatitis as seen in malaria or dengue. Apart from the general investigations, of course, we need specific investigations targeted towards malaria, dengue, chikungunya and leptospirosis. We would very often know what kind of epidemic our region has and we might be able to tailor this test, and sometimes if we do not have an idea, we might have to do one test from each of them. For malaria, of course, the primary test is a peripheral smear. We can do both a thick as well as a thin smear, and nowadays there are rapid diagnostic tests available. These are strip tests and they test for two types of antigen. First is LDH. LDH is present in all parasites and therefore can help me to diagnose malaria, and we can also have the histidine rich protein which is present only in the falciparum one, so it will help me to differentiate whether this is falciparum or the otherwise which is vivax. Dengue can be diagnosed using NS1 antigen test. This is an ELISA based test and the limitation here is this is positive only in the first 5 days. After first 5 days of fever are over, I would typically look for an IgM capture ELISA, and this test is positive from the 5th day onwards right up to the 2nd month. There are other tests for dengue known as the RT-PCR or the culture test, and both of these are not usually done. Coming to chikungunya, the most specific test is RT-PCR for viral RNA, but again not very commonly done. What is commonly available and done is the serology IgM antibody via ELISA for chikungunya. Virus isolation can also be done, but again this is predominantly for research purposes rather than routine clinical practices. For leptospirosis, rapid CAR tests are easily available. This would again test for the IgM antibody against leptospirosis. The gold standard test is microscopic agglutination test or MAT, but this test is not easily available. We can do an ELISA for IgM, that is available, and sometimes we can do an RT-PCR or culture of leptospirosis, but again it would have a limited availability in the community. Once we have sent the basic investigations and some specific investigations, even before we get back the reports, we need to start the therapy. And while starting the therapy, the first question in our mind is, where do we need to treat? Is this an OPD based management or do we need to hospitalize? Remember, any patient who is appearing sick should be hospitalized. Now what would that mean? That would typically be a patient who is hemodynamically unstable. We need to look at the heart rate, patient in shock, or a patient having ARDS. A patient who has poor oral intake could be because of nausea or vomiting. A patient who has an altered neurological status. A patient who has renal injury, or sometimes simply because the patient has a poor social support. Now the first line of management for all febrile illnesses is fluid management. If the patient has been managed on OPD basis and can have oral intake, we should advise for good oral intake of fluid. Typically this would mean around 2 to 3 liters of oral fluids per day. But if the patient has been hospitalized or has less fluid intake, then we should consider IV fluids, typically normal saline. While I'm giving normal saline, I need to be watching out for blood pressure. I need to watch out for the heart rate, urine output and JVP. And I do not want the hematocrit to change beyond 20% because that could be a marker of hemoconcentration. I'm also watching out for the chest for crepitations to look for fluid overload. We typically would start with 5 to 7 ml per kg per hour of IV fluids. That would be roughly around 1 pint of NS in the first hour, and then we would gradually lower down the rate, monitoring the patient to 1 point given over 4 to 5 hours. Patients have come to us with fever, and the drug of choice for this is paracetamol. We need to be liberal in our use of paracetamol at least for the first 1 to 2 days, and that would mean giving a 500 mg tablet around 4 times a day. Patients can have associated gastritis, and proton pump inhibitors are the drug of choice. We need to be careful about avoiding 2 drugs over here. First, we need to avoid aspirin, and second, we need to definitely avoid steroids in all such acute febrile illnesses. We need to monitor the patient for his platelet count, and we need to consider transfusions appropriately. Now it's important to remember that if the patient does not have any signs of bleeding, there is no one cutoff for transfusion of platelets, especially in dengue. On a safer side, we tend to transfuse once the platelet count are below 10,000. But again, that's not a guideline, that's more of a practical thing that we do. What is the guideline is we need to transfuse any patient who has any signs of bleeding. We need to of course consider supportive care in form of requirement of mechanical ventilators for ARDS or requirement of dialysis if the patient has acute renal injury. Moving towards specific therapy, if our diagnosis is malaria, for falciparum malaria, we need to give artesunate plus SP combination or artemether plus lumefantrine combination. Both of them are given for a period of 3 days. And if it is vivax malaria, we need to give chloroquine for 3 days, and along with that, to prevent a relapse, we need to give primaquine for 14 days. Remember, primaquine, before we give that, we have to test the patient for any deficiency of G6PD enzyme. For leptospirosis, depending on where the patient is, in the community that is OPD based, we could give doxycycline, or if the patient has been hospitalized, we can use either IV ceftriaxone or sometimes penicillin. Management of acute febrile illness is not complete without thinking of the preventive measures, and all patients should be educated so that they do not have relapse of this and their family members do not suffer from similar consequences. This has been a long tutorial. I'm sure there are going to be questions. If there are any questions, feel free to reach out to me. Till then, thank you so much and Jai Hind.